Prodromal symptoms, a complicated clinical challenge, a case study. Cardiac-related prodromal symptoms are non-specific warning symptoms of an impending cardiac event. Lack of early prodromal symptoms recognition from patients and clinicians may increase cardiac-related morbidity and mortality. Now, the most common prodromal symptoms prior to an acute myocardial infarction include fatigue, sleep disturbance, shortness of breath, indigestion, anxiety, with less than 30% of individuals reporting having chest pain or discomfort. Prodromal symptoms typically may occur days, weeks, or months prior to the actual heart attack. Both men and women report chest and arm pain, prodromal dyspnea, fatigue, dizziness, headaches, sleep disturbance, and anxiety as the most prevalent symptoms. Non-specific prodromal symptoms, a precursor to cardiac events, remain a challenge for healthcare professionals to recognize, treat, and screen. Clinicians need to focus their attention on the early pre-hospital warning signs of coronary artery disease. We present the case of Susan, a 65-year-old woman returning for her routine diabetic clinic visit. She has a history of type 2 diabetes, hypertension, obesity, and hyperlipidemia. Functional inquiry revealed that she was able to perform instrumental activities of daily living and had no decrease in her exercise tolerance. Her family history revealed a father with myocardial infarction at 55 years of age, a mother that died at 62 of coronary artery disease, and her brother currently is a diabetic, also with coronary artery disease. Her recent history, she has a 1-month history of every few days experiencing unprovoked nausea and vomiting, accompanied occasionally by chest discomfort, and was relieved on its own within a few minutes. In addition, Susan has reported a 3-week history of increasing insomnia. A cardiac workup in the emergency room was unremarkable. Physical examination revealed she was in no apparent distress. Her blood pressure was 120/60. Her heart rate was sinus rhythm at a rate of 70 beats per minute and regular. Normal breath sounds. She had normal heart sounds, normal S1 and 2, and no S3 or 4 heart sounds. No rubs or murmurs. Her abdomen was slightly tender in the epigastric area. The differential diagnosis was cholecystitis, gastroesophageal reflux disease, or diabetic gastroparesis. The interventions included Pantaloc 40 mg OD, abdominal ultrasound, an ECG, routine blood work, endoscopy, and an internal medicine referral. Her results revealed the abdominal ultrasound. It was suspicious for fatty infiltrates, but otherwise unremarkable. Her ECG findings indicated normal sinus rhythm with non-specific T-wave changes in the anterior leads. Routine blood work was done, which included complete blood count, blood urea nitrogen, electrolytes, creatinine, random glucose, creatinine kinase, troponin 1, international normalized ratio, and partial thromboplastin time. And she was referred to internal medicine. The endoscopy was normal. The internal medicine report indicated that vomiting was probably triggered by GI issues. Rather, she was clinically stable. Because she had a high family history of cardiovascular disease and high level of possible cardiovascular risk, they decided to do an exercise stress test. The exercise myocardial perfusion study was completed and revealed a resting heart rate of 80 beats per minute, a maximum of 137 beats per minute after exercising for 5 minutes, achieving 88% of the target heart rate. During that time, the stress test revealed ST depression across the anterior leads as seen by the red arrow. SPECT cardiac images demonstrated moderate-sized, severe, reversible perfusion defect across the mid to distal anterior septum towards the apex. No fixed perfusion deficits were present. The gated SPECT demonstrated good left ventricular wall motion. Ejection fraction following the stress was 63%, and the resting was 68%. The interpretation revealed that there is a moderate-sized region of ischemia across the anterior septum apex, and this corresponds to the left anterior descending artery territory. There was no scar present. The ECG was positive stress test. She was sent for an emergent cardiac catheterization. We can see in the top angio picture the diseased artery. A PCI was performed with insertion of a drug-eluting stent in the LAD as seen in the lower image. Prodromal symptoms may present a challenge to primary care providers that are often overlooked or incorrectly recognized as non-cardiac in nature. Prodromal symptoms of fatigue, anxiety, shortness of breath, sleep disturbance, or nausea, example, may not be recognized as cardiac in origin because of other concurrent conditions present. These symptoms, transient in nature, are a red flag for clinicians to take note of that are reflective of suspicious prodromal symptomology, which may lead to an acute coronary syndrome. Preemptive recognition of prodromal symptoms is imperative for effective targeting, screening, diagnosis, and timely treatment to identify those at risk for future coronary artery disease-related events. Prodromal symptoms may both be typical and/or different. Atypical symptoms including unusual chest pain, anxiety, fatigue, sleep disturbance, gastrointestinal complaints, dizziness, shortness of breath, and unusually located aches and pains. Symptoms are often transient in nature and are a cardinal sign to take note of, which may indicate prodromal symptomology. Those who experience prodromal symptoms are more likely to report the same or similar symptomology during their acute coronary syndrome presentation. Interpretation of cardiac-related prodromal symptoms in the context of patients' comorbidities and other chronic conditions warrants use of psychometrically robust prodromal symptom screening tools. To date, there is only one tool published available that has been used in practice to screen for prodromal symptoms, the McSweeney Acute and Prodromal Myocardial Infarction Symptoms Survey. This instrument assesses 37 acute and 33 prodromal symptoms and has established content validity and acceptable retest reliability. In conclusion, both men and women experience prodromal warning symptoms months, weeks, or even days prior to a cardiac event. Routine preemptive screening of prodromal symptoms in clinical practice should be included when obtaining a patient's medical history, as well as may serve to identify those patients at risk for development of CAD. It may provide evidence-based rationale beyond clinician intuition as well that would support early diagnostic cardiac workup in order to decrease cardiovascular-related disability, poor health-related quality of life, and reduce early death. Preemptive screening for cardiac-related prodromal symptoms in men and women need to become a standard in clinical practice. This would potentiate early diagnosis, effective risk modification, and decrease CAD-related morbidity and mortality. For more information, email me or check our website out, available on the screen. Thank you very much.